Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina ki uta, kia mā taratara ki tai. E hi aki ana te atakura, he tio, he huka, he hauhu, tihei, mauri ora. Tēnā koutou, tēnā koutou, tēnā koutou katoa, nau mai ki tēnei hui mō te mati pūkura. Ko Laird Cameron tōku ingoa, ko Tamaki Makaurau ahau, he rata ahau, ke te pūriri o te ora, he tangata tiriti ahau, manawatia a matariki. Kia ora, and welcome to this Post-ASCO 2025 TOGA Symposium. My name is Laird Cameron. I'm a thoracic medical oncologist working in Auckland, New Zealand, and the New Zealand rep on the TOGA Scientific Committee. I'll be chairing tonight's session. We acknowledge the Indigenous peoples across both Australia and New Zealand. TOGA recognises the traditional custodians of the lands across Australia on which we live and work, and we pay our respect to elders past, present and emerging. TOGA also acknowledges Māori as tangata whenua of Aotearoa, New Zealand, and as treaty partners with the Crown as agreed in Te Tiriti o Waitangi. Thank you all for joining us, and to Pfizer for supporting this webinar. Welcome to Rachel, Alex, Lavinia and Mel, and thank you in advance for all of the work that you've already done for tonight's talk. I know many of you are practicing oncologists and it's hard to protect that time to review the latest evidence, let alone get to Chicago. And that's why I love these sessions. Days and days of content gets condensed down and put into the Australasian context. The Thoracic Oncology Group of Australasia is on a mission to prevent, treat and cure thoracic cancers. To do that through research, trials, education and advocacy. I've been a member since before we were named TOGA, and you can become a member too. There's a QR code on the screen. Please join up. We welcome a wide range of members across all disciplines, professions and consumers. All right, so here is our lineup for this evening. We have 4 experts from Sydney, Melbourne and Adelaide with 20 minutes each to cover early stage non-small cell lung cancer, advanced stage non-small cell lung cancer, small cell lung cancer and mesothelioma, and then poster picks from Mel to finish off with. I'll be introducing each speaker as we go. And the Q&A session will be after all of the sessions, which gives you plenty of time to submit your questions as you're listening to the talks. And you can find the live Q&A tab to the right of your screen. All right. So first up, we're going to crack straight into it. It is my pleasure to introduce Associate Professor Rachel Roberts-Thomson, a medical oncologist at the Queen Elizabeth Hospital and Cancer Care in Adelaide. Rachel's a medical oncologist in South Australia with a strong interest in treating patients with thoracic malignancies as well as melanoma. She enjoys being a PI on clinical trials, clinical research projects, as well as supervising and teaching. Her focus has been on immunotherapeutics and targeted therapies with the excitement that exists in that field. Over to you, Rachel.
Thank you, Laird, for that introduction. And my brief today is to talk about early stage lung cancer updates from ASCO. An overview of my talk tonight is going to be talking about a poster. Mel's got most of the posters to summarise, but I've got this one. So this is a 14 gene signature used in early lung cancer. So I'm going to summarise this really interesting poster. The talk is really going to focus on NeoAdora data and Checkmate 816. So they'll be the main focuses, with small mentions to ALNEO and then some little brief mentions to R-ALPS and a really interesting SWOG SABRE study. And a bit of mention on the minimal residual disease data presented from AG and Checkmate 77T and the DART study. So obviously it is really important to keep up to date with the data, and in particular we're day -14 now for the National Lung Cancer Screening Program coming into being. Next slide, please. I'm just having trouble moving them along. There we go. So hopefully there'll be some gems and pearls from the updates that I have from the ASCO lung data meeting just happening. So this poster really sort of caught my eye. This was a 14 gene assay that was prospectively reviewed in early lung cancer. So for patients with resected stage 1A to 2A non-small cell lung cancer, this was a prospective study using this 14-gene assay. And those patients who were found to have intermediate or high risk lung cancer through this gene assay were randomized to receive adjuvant chemotherapy or not. There are approximately 200 patients, and the standout from this study was that at 24 months, the disease-free survival was 96% in the chemotherapy receiving group and 79% in the observation group with a hazard ratio of 0.22. So that was really quite incredible, I thought, with this 14-gene assay. And the study was stopped early after these results. Now, we use some of these assays in other solid tumours, but I thought that this was of particular interest, especially with lung cancer screening coming to our network soon. But just an interesting thing to remark upon. Now, moving on, there was a lot of discussions, general discussions about the landscape and some fantastic reviews by some very impressive speakers at ASCO, with some great summary slides as well about the landscape, which this audience knows is becoming more complicated, more agents to use. And so just a couple of little pictures there to outline the landscape as it stands. And highlighting there, just with circles there, our PBS reimbursed treatments in Australia in the early lung cancer space. We have the ability to prescribe the Checkmate 816 regimen and the Empower 10 regimen in the adjuvant resected patients with high PD-L1 expression. And we've got the ability to also use osimertinib following resection for patients with EGFR mutated lung cancer for 3 years as per the ADAURA study. So then moving on to some of the presentations. So this is Neo-ADAURA, and it was presented at ASCO by Dr. Shaft and then published at the same time in the Journal of Clinical Oncology. So Neo-ADAURA, we're going to sort of have a bit of a dive into this this evening. So Dr. Shaft presented the neoadjuvant osimertinib with or without chemotherapy versus chemotherapy alone in resectable EGFR mutated lung cancer Neo-ADAURA study. The background to this study was talked about by Dr. Shaft. So she sort of stated that neoadjuvant chemotherapy and chemo-IO for resectable lung cancer with an EGFR mutation really only resulted in very low responses. And also she commented on the fact that immunotherapy in that setting really wasn't appropriate. The basis for this study was to hopefully reduce disease progression, precluding surgery in patients by giving it before surgery, to improve surgical outcomes or improve long-term treatment outcomes. And that was sort of the basis for Neo-ADAURA. This is the schema for Neo-ADAURA. So you can see it's a phase 3 study for patients with completely resectable EGFR mutated stage 2 to 3B non-small cell lung cancer. Key inclusion criteria were that they had to have resectable disease, histologically confirmed non-small cell lung cancer, an exon 19 deletion or L858R, and good performance status. They were randomized in a 1-to-1-to-1 fashion to osimertinib for 9 weeks with platinum doublet chemotherapy for 3 cycles, or osimertinib monotherapy for the 9 weeks, or to a platinum doublet for 3 cycles, followed by their surgery. And then the sponsors were able to supply adjuvant osimertinib as to the ADAURA data for those who completed surgery in all arms. Stratification was by stage, substage, whether patients were of non-Asian background and the type of mutation that patients had. It was a little interesting, but the primary endpoint was major pathological response, defined by having less than or equal to 10% viable tumour, residual viable tumour after the neoadjuvant treatment, with secondary endpoints being event-free survival, pathological complete response, nodal downstaging, and safety. So they're the endpoints of the study. The baseline characteristics of the groups were fairly balanced. There were more women, as you would expect from this patient cohort. There were about 25% of non-Asian participants. There was a balance, a real split between the different types of EGFR mutation, and a balanced group of stage 2 and stage 3 patients, about 50-50 split. And about 35 to 40% of patients between the groups had N2 disease. Now, what was interesting was that the majority of patients got to surgery. So that's always a good thing to know. There were less patients getting to surgery in the chemotherapy-only group. So 8% of patients didn't get to surgery in the chemotherapy-only group because they had progressed prior to surgery, as opposed to 2% in the osimertinib-containing arms. Now, this is the sort of the primary endpoint. This is the data from the main piece to take home from NEO-ADAURA, the MPR rates. And you can see here that the MPR rates were statistically significantly higher within both osimertinib-containing regimens. So 26% for OSI with chemotherapy compared to 25% MPR rate with OSI monotherapy, and a very low, potentially surprisingly low for EGFR mutated lung cancer patients, a 2% MPR rate for those receiving neoadjuvant chemotherapy alone. And that was statistically significant, the difference between the individual OSI-containing groups and chemotherapy alone. MPR by subgroup didn't really show anything particularly interesting when you stratified for the factors that were predetermined. Interestingly, there was some nodal downstaging to note. So over 50% of patients with baseline N2 disease, although a large number of patients with N2 disease in the study, were downstaged at surgery within both OSI-containing regimens. So that's something interesting and potentially useful to note compared to those that received chemotherapy in the neoadjuvant sphere. We've also got a waterfall plot here that demonstrates the depth of pathological response. So this is not radiological response, this is pathological response by blinded independent central review, where the pathologist had a look at the specimens and estimated the response within the tumour bed to the neoadjuvant regimen. And you can see quite nicely with OSI and chemotherapy, the 26% MPR rate with about 4% CR. And in the OSI monotherapy, 25% MPR rate with a 9% CR, and a very small number of patients having MPR in the chemotherapy-only neoadjuvant group. Now, event-free survival presented was very, very immature. Only 15% maturity has been reached in terms of the presentation that was given at ASCO this year. So I guess we're going to be hearing more about this. So very, very early data. But you get a bit of an idea that there might be curves separating there between the OSI containing arms and the chemotherapy-only neoadjuvant receiving patient arm. Safety, I guess this audience is probably fairly familiar with the toxicities of osimertinib with or without chemotherapy, and there wasn't any particular standouts with the safety reporting that I could identify. 2 patients on the OSI monotherapy arm got pneumonitis, but neither of these patients didn't get to surgery. So safety, I think, there was probably to be expected and nothing untoward. So Dr. Sharp concluded that neoadjuvant osimertinib with or without chemotherapy should be considered when planning treatment for patients with resectable EGFR mutated stage 2 to 3B non-small cell lung cancer. So some of my thoughts were that this really is very early data. It was interesting that MPR was chosen as a primary endpoint for this study rather than potentially a more robust endpoint. It'll be very important to look at EFS, OS between the groups, but also the numbers in the groups that go on to have adjuvant osimertinib as per the ADAURA data. Dr. Sharp reported that currently this is quite balanced between the groups, with 91% of patients in all of the groups receiving osimertinib as would be standard of care at the moment. So we might get some valuable data about whether the neoadjuvant approach actually improves on these outcomes. This also might be a useful regimen for larger cancers with N2 disease potentially. And there's a big question about whether we actually need chemotherapy. FLAURA2 in the metastatic setting suggests that adding in chemotherapy to osimertinib can be helpful up front. And so it's going to be interesting to see whether this might bear out an EFS benefit, because the MPR rates are really quite similar in both osimertinib-containing arms. So quite an interesting presentation at ASCO on this NEO-ADAURA data. Moving on now, just a really brief comment on ALNEO. It's an ALK study for Mel. So ALNEO is a smaller phase 2 study using the similar kind of neoadjuvant strategies. It's not a randomized study. ALNEO had patients with resectable stage 3 non-small cell lung cancer who were candidates for resection, and they received 4 weeks of neoadjuvant alectinib followed by surgery, and then alectinib for 2 years as per the ALINA data, which isn't available yet at this time in Australia. Their MPR rates from this regimen were 42%. So this is quite an interesting study. Still, it's not a randomized study, but following the same vein to a neoadjuvant like regimen for patients with mutations in resectable non-small cell lung cancer. Now, moving on to the real highlight in the early lung cancer space at ASCO 2025, and this is Checkmate 816. So Patrick Ford from Ireland presented the Checkmate 816 overall survival data, and it was subsequently published in the New England Journal of Medicine, essentially at the same time. Again, in ASCO this year, they had some takeaways at the beginning of the talk, I think, to enable people then to have a little snooze if they wanted to or not. And so takeaways were presented at the start of the talk, giving away the sort of the punchline that Nivo and chemotherapy were found to have statistically significant and clinically meaningful overall survival benefit versus chemotherapy. Okay, so the background of Checkmate 816 probably doesn't need to be described too much. It's been previously presented several times, but this update at ASCO this year was the presentation of the results of the pre-planned final analysis of overall survival from Checkmate 816 at a minimum of 5 years of follow-up. And Patrick did say that Nivo and chemo is the sole neoadjuvant-only chemoimmunotherapy regimen approved in many jurisdictions. He didn't mention Australia there, but obviously, yes, this is a regimen that we have been utilising in Australia, and it's great to see this overall survival data presented. So just reminding people about the Checkmate 816 study design. So patients with resectable, and at this stage we were using the AJCC 7th edition of staging. Now we're on to the 9th edition. So eligible stage 1B, which would be now our stage 2 patients, to 3A non-small cell lung cancer patients, good performance status, no EGFR mutations or ALK alterations, if not all patients have these tested for, were randomised in a 1-to-1 fashion to receive nivolumab, 360 milligrams with platinum doublet chemotherapy for 3 cycles, or chemotherapy platinum doublet for 3 cycles, followed by restaging and then surgery. And then there was the ability to receive optional adjuvant chemotherapy and or radiotherapy. Primary endpoints, PCR and EFS, have been presented before. Key secondary endpoints, we're going to hear the results now, and we heard these at ASCO of overall survival. So here it is. The sort of really key take home, I think, from the Checkmate 816 is that Dr. Ford presented the overall survival at 5 years of 65% of patients being alive and well who received chemotherapy and nivolumab for those 3 cycles, followed by the surgery, compared with 55% who received chemotherapy alone. And this was a hazard ratio of 0.72, and you can see the separation of the curves there, the survival curves. So this was a great result in terms of overall survival benefit. Looking at the subgroups, the key subgroups, just pointing out that there was a benefit for patients with stage 1B to 2 compared to 3A of the chemo and Nivo receiving arms. Similar benefits between the different subtypes in terms of histological subtypes, squam or non-squam. And what became evident was those with higher PD-L1 expression seemed to glean more benefit of the chemotherapy and nivolumab approach. There was also the use of carboplatin in quite a number of patients, which is always useful to have that option as well in the clinic, and that seemed to be a useful strategy in the neoadjuvant approach, and often can be a bit better tolerated for our patients. Again, just showing the Kaplan-Meier curves of those important subgroups. In the top graph here, we can see the improved, so that there is a greater numerical difference if patients had stage 3A non-small cell lung cancer for those receiving chemotherapy with nivolumab, so greater numerical benefit compared to having a lower stage, but still the separation of the curves there showing that both stages did benefit from chemotherapy and nivolumab before surgery. In terms of PD-L1 expression, there is quite a separation of the curves for the patients who had positive PD-L1 expression. You can see numerically 78% versus 58% at 5 years, and a trend towards improvement in the no expressors, but this wasn't statistically significant. So we'll have a little bit of a talk about that, I'm sure, as we go into question time and so forth. Now, another really important thing that came out of Checkmate 816, it's always very important when you've got a patient in front of you to, very useful to be able to tell them if they have a good pathological complete response, that actually does correlate with outcome. And we've got evidence to say that, yes, that really does correlate with outcome if you do have a pathological complete response following your neoadjuvant treatment. And this overall survival data by pathological complete response status was presented at ASCO, reminding everybody that 24% of patients had a path-CR in the group receiving chemotherapy and nivolumab compared to 2% with chemotherapy alone. But it is very meaningful to have that path-CR, and it's something that we can tell our patients it does correlate with outcome. There was also data presented about ctDNA clearance and this being a correlate to good outcome. So this was ctDNA clearance prior to surgery. So for those patients who had detectable ctDNA at cycle 1, this was checked again before their surgery. And if patients cleared this, that correlated to improved outcome. And we've got the survival curves here showing that improvement. So a couple of other important things. Does PCR correlate with outcome for chemo-IO? Yes, I think this was shown by Patrick Ford at ASCO. And does ctDNA clearance correlate with outcome? We've got graphs and evidence to suggest that too. Safety, there weren't any new surprises at this update. Very similar data to which has been presented before for Checkmate 816. So Dr. Ford concluded that Checkmate 816 is the only phase 3 trial of neoadjuvant only chemoimmunotherapy to demonstrate a statistically significant overall survival benefit for resectable non-small cell lung cancer patients. And that was really great data to hear at ASCO. So some thoughts, this really does lend more weight to using neoadjuvant chemo-IO for our patients in the clinic without actionable genomic alteration. We obviously still have a bit of work to fine-tune the patients who benefit from adjuvant immunotherapy because of the many perioperative studies that are underway. And again, that might be those patients who have a non-PCR, low PD-L1 expression or no ctDNA clearance. So data coming through that we might need to fine-tune this with time. Now, our Western Australian medical oncologist, Dr. Tim Clay, asked Patrick a question, which was really very important at ASCO. It was a fantastic question. He got up there and asked Dr. Ford what he would do for a patient with PD-L1 negative resectable non-small cell lung cancer. And Patrick did say that this is obviously very nuanced, but in Checkmate 816, he thought about 1 in 6 or 1 in 7 patients would have a PCR with PD-L1 negative tumours. This sort of from knowing the data very well, because it might not be the best biomarker, and he did sort of suggest that maybe the treatment for these patients may need to be fine-tuned in the future. But that was wonderful to hear Tim asking that very pertinent question. Okay, so moving on, there was this really interesting study. It's a radiation study presented by Megan Daly, the SWOG or NRG S1914 study. And this was patients who were randomised if they had very localised lung cancer with no nodal involvement to receive SABR, or atezolizumab for 8 cycles in a sort of a peri-treatment approach with their SABR, and there wasn't found to be a survival benefit. Now, there wasn't data to look at PD-L1 expression that will be analysed down the track, but this was a negative study presented by Megan Daly at ASCO. The other comment on that SWOG study where there were more toxicities in the immunotherapy containing arm, as was to be expected. ALPS was a Chinese study, just run in China, but an interesting randomised double-blind multi-centre phase 3 study of a PD-L1 inhibitor, Ben-Mel, I'm going to call it Ben-Mel, with or without anlotinib, a VEGF inhibitor, as consolidation therapy following chemotherapy for patients with unresectable stage 3 non-small cell lung cancer. And this study showed a benefit of adding in the VEGF inhibitor with the PD-L1 inhibitor. And I thought this was interesting and potentially worth a bit of interrogation, but not something that will probably change our practice at this time. And just a very brief mention, it was sort of more of a theme at ASCO, this testing for minimal residual disease or looking at ctDNA clearance, and Martin Rick presented the Aegean data, analysing post-surgical MRD status and finding that patients with residual disease would do more poorly. Again, in the Checkmate 77T, Tina Casconi presented data on a similar vein, looking at patients with persisting ctDNA that would also do not so well. And Oslag Helland from Oslo presented some really eloquent data of the DART study for patients treated with chemoradiotherapy and then durvalumab, and patients with persisting ctDNA testing had worse progression-free survival than those who cleared their DNA. And so fairly sort of logical things, but may end up being therapeutically able to be addressed as time goes on if we are able to use these tests in our clinic. So I think that's probably really all from me at this stage. Talked about a poster, a 14-gene signature. Interesting, potentially, we've got early the screening coming in, and having tools like this could be potentially very useful in the future. Really sort of spent some time talking about Neo-ADAURA. Neo-ADAURA is not quite ready for prime time, but very interesting. Checkmate 816 is practice change confirming, and we've talked about some other interesting studies from ASCO 2025 as well. So thank you.
Thank you, Rachel. Some exciting early stage data there. We're going to move straight into the advanced stage non-small cell lung cancer topic, and I'm introducing Dr. Alex Davis, who's a medical oncologist in Northern Sydney Cancer Centre. Alex is a medical oncologist with an interest in thoracic malignancies. His focus includes biomarker-directed therapy, personalised medicine, and patient-centred decision-making. He's a strong believer in clinical trials, improving patient outcomes, and is an active participant in several industry and TOGA-led clinical trials. Currently enrolled in a PhD at the university looking at KRAS mutant lung cancer and how co-mutations mediate clinical outcomes to immunotherapy. I better be quiet, Alex. You've got heaps of good stuff to run through. Over to you.
All right, thank you. And thank you to TOGA and Pfizer for sponsoring this, and TOGA for the opportunity to talk. So, not a lot of practice-changing stuff for advanced non-small cell lung cancer at ASCO, and some interesting stuff that I thought may change practice in the future, and some early phase trials of biomarker-directed therapy that we can go through. In the interest of time, I'm not going to talk about Herthena, which was a negative patritumab deruxtecan study for ADC in progressive EGFR mutant lung cancer. Also not going to talk about the Savannah study in the interest of time, but we'll talk about the Savo-Aussie combination in detail. So to move on with my slides. Yes, thank you. So I thought this was probably the most interesting oral abstract for advanced non-small cell lung cancer at ASCO, and just really relates to the time of day that we give chemoimmunotherapy for advanced non-small cell lung cancer. And this was presented by Dr. Zhang from the Hunan Cancer Center Hospital. So I'll just flick to the study design and just talk a little bit about the background while that comes up. So essentially, there's been quite a number of retrospective studies that have identified that patients who are treated with immunotherapy earlier in the day do tend to do better. And this has been demonstrated across a variety of cancers: lung cancer, melanoma, GI cancers. Obviously, there's a lot of confounders to that. So this group, which was predominantly based in China, Hong Kong, Switzerland, and France, ran this fairly pragmatic phase 3 study where patients were randomized 1-to-1 to early in the day treatment group, where chemoimmunotherapy was started and finished before 1500 hours, or the late day group, where treatment was commenced after 1500 hours. There were no stratification factors. You could have stable brain metastases, driver mutation negative, and the primary outcome there was PFS by Burke. So moving on, I won't spend much time on the patient characteristics beyond to say that PD-L1 expression was fairly well balanced between the two groups. As this was a study conducted in China, you can see that sintilimab, which is an immune checkpoint inhibitor, which is licensed for use there, was the predominant immunotherapy agent used. Moving on to the primary outcome of PFS, you can see here that there's a fairly significant and large improvement in median progression-free survival of 11.3 months in the early treatment day group versus the late treatment day group, with a median PFS of 5.7 months, hazard ratio 0.46, and statistically significant. This was broadly seen in most of the subgroups, except you can see here for patients with liver metastases. Moving on to overall survival, this was, relatively early data. We can see a median follow-up of 23.2 months and median OS not reached in the early today treatment group. However, you can see here again a statistically significant improvement in median overall survival with a hazard ratio of 0.45. Again, not much to sort of delineate on subgroup analysis. There were some exploratory endpoints that the investigators were looking at, and primarily related to PBMCs, or circulating T cells. We can see here that this was measured early in the day. For the patients allocated to the early today treatment group, there was greater expansion of CD8 T cells compared to CD4 T cells. The investigators couldn't really elaborate on why this may be. So in conclusion, they've stated basically they've demonstrated that an early in the day chemoimmunotherapy infusion improves PFS and OS. Why that is not necessarily clear. However, they concluded that this should be a stratification factor or documented in further clinical studies, which, I think is very reasonable. For me, I thought this was very interesting because a fairly simple intervention with quite a large treatment effect, which seems relatively low cost. Why this is a bit unknown. We all don't have a journal paper to sort of go through this in detail, so it'll be very interesting to see that when it comes out. It'd be great to see this in a number of different populations. And I guess the real challenging thing for me would be that if there was randomized evidence for single agent immunotherapy, because I don't know about everyone else, but in my center, these patients are just sort of slotted where they can fit in. And if I have to tell our day therapy num that these patients have to be treated at 8 a.m., I'm not going to be very popular. So it will be interesting to see how this plays out. So moving on to abstract 8505, which was the combination of savolitinib and osimertinib versus chemotherapy in EGFR and MET amplified non-small cell lung cancer after disease progression on an EGFR TKI, the SACHI study presented by Dr. Liu from the Shanghai Chest Hospital. So while you're all looking at design, as you might be aware, MET amplification is a resistance factor or resistance mechanism for EGFR TKIs, particularly with osimertinib. And we do see this in about 20% of patients, and it generally portends a worse prognosis. So this study looked to give savolitinib, which is a highly selective MET inhibitor, together with osimertinib, and see whether this improved outcomes compared to platinum-based pemetrexed chemotherapy. So looking at the inclusion criteria, probably the most important thing to say here is patients could have a first or second generation TKI. This study was conducted primarily in China. The most important thing was that MET amplification selection criteria differed between the two groups. For first and second generation TKI, you could have a MET copy number gain on FISH of 5 or more. But if it was third gen TKI, such as osimertinib, it had to be greater than 10. So 1-to-1 randomization is open label study, stratification factors, brain mets, whether use of third gen TKI and specific EGFR mutation, and crossover was allowed. Looking at the consort diagram, I guess the most pertinent thing here is really over 1,000 patients were screened and only just over 200 were randomized, so pretty significant dropout looking for MET amplification. So 41% of patients screen failed on this basis. Also pertinent to look at 43% of patients in the control arm crossed over to active treatment. I won't dwell on these characteristics beyond to say that there are no real differences to see there. Approximately a third of patients had brain metastases. I'll just bring your attention mostly here to the ITT population. You can see here that the combination of savolitinib and osimertinib improved progression-free survival with a median PFS of 8.2 versus 4.5 in the chemotherapy arm and a hazard ratio of 0.34. And this was significant. Something more in line with our practice, our prior third-gen TKI group. You can see here that this was still statistically significant for PFS with a hazard ratio of 0.32. I won't dwell on the subgroups beyond to say that they are generally favour treatment of the combination. And there was a statistically significant improvement in investigator-assessed overall response rate of 58% with the combination versus 34% in the chemotherapy arm. Overall survival was still immature with a maturity of 40%. Obviously, to me, these curves look pretty close, so we'll just have to see how this data plays out over time. Safety is always pretty relevant. I guess looking at a tablet-based combination, we'd like to think it was less toxic than chemotherapy. For me, looking at this data, I wouldn't say it was significantly less toxic. There was a relatively even split of grade 3 treatment-related adverse events, and 47% of people having dose modification on the combination arm. Looking at the adverse events, to generalize, you could say there was perhaps more hematological toxicity with chemotherapy, more anorexia, peripheral edema, and hyperalbuminemia with the combination of the MET inhibitor and osimertinib. And the authors concluded that savolitinib and osimertinib were new chemotherapy free option for patients with EGFR mutation, positive non-small cell lung cancer, and MET amplification. I won't go into my thoughts until we moved on to this next abstract, which is sacituzumab tirumotecan, or I'm going to call it Sac-TMT, which was a TROP2 ADC used in the OptiTROP Lung 03 study. And this was a randomized study conducted in China, presented by Li Zhang. And just to look at the study design, while you have a look at this, we've seen a number of TROP2 ADCs being used in the treatment of, all malignancies, but certainly non-small cell lung cancer, and the studies aimed at patients with an EGFR mutation who've progressed on EGFR tyrosine kinase inhibitor and platinum-based chemotherapy, control arm, our old favorite, docetaxel, and 2-to-1 randomization to Sac-TMT, with primary endpoint being over ORR by blinded independent central review. To look at disposition here, I guess the things that stand out to me here is, 46 patients were randomized to docetaxel, and all of them received treatment with docetaxel, which is in contrast to some other randomized studies. And we can also see that 36% of patients crossed over from the control arm to Sac-TMT. I won't dwell on the patient demographics and characteristics beyond to say that, the majority of patients, or over 90% of patients, were treated with a third-generation TKI. And we can see here by the primary outcome, there was a statistically significant difference in ORR by blinded independent central review, with a overall response rate of 45% with Sac-TMT and 15.6% in docetaxel, which is a lot more than what I generally quote to patients, but nevertheless what they found in the study. Looking at progression-free survival, we can see here there's a significant improvement in median PFS of 6.9 months with Sac-TMT versus 2.8 with docetaxel. And for overall survival, again, this was quite early, median OS not reached in either group. However, this did meet the criteria for statistical significance with a hazard ratio of 0.49. As with all ADCs, toxicity is relevant. And I guess looking at this slide, I wouldn't say that it was better tolerated than docetaxel. The main thing that the group wished to point out that there was no ILD with Sac-TMT, but certainly there was a lot of hematological toxicity. So this will be an interesting drug to follow. And there are several phase 3 studies looking at this in combination with osimertinib in EGFR mutant non-small cell lung cancer. All right, moving quickly, abstract 8512, which was, I'm just going to call this ABBV-400 or TEMAB-A, which is c-MET targeting protein, or c-MET protein targeting ADC in patients with EGFR mutant lung cancer. So this is presented by Dr. David Sommerhalder from Next Oncology, San Antonio, Texas. This is just a phase 1 study looking the EGFR mutant lung cohort and the dose expansion arm. There were 2 doses used, and they didn't go into the inclusion criteria beyond to say that they had to be previously treated with platinum-based chemo and a TKI. I won't dwell on this beyond much to say that these are heavily pre-treated patients with median lines of treatment having 3 previous lines of treatment, and 78% of patients having previously been treated with osimertinib. Suffice to say, this drug was quite active with an overall response rate of 63%. And you can see here that 78% of patients with a response to this was maintained through 24 weeks with a median PFS of 10.9 months. Again, as with all ADCs, toxicities are pertinent, and for the purpose of this study, a treatment emergent adverse event disease progression was considered a TEAE, but 12% of patients experienced a fatal TEAE. Again, hematological toxicity was quite relevant, and there was some ILD with this compound. So for my thoughts for these group of studies, just to say that Herthena, which I didn't discuss in detail, but this was a promising ADC, but it doesn't seem like this will progress further beyond the Herthena study. The savolitinib and osimertinib combination seems quite promising. However, we need OS maturity and a global study. So the Saffron study, which is there were some Australian sites running this, looking at MET amplified EGFR mutant lung post osimertinib, and we look to see the readout of that. These 2 drug ADCs, Sac-TMT and TEMAB-A, obviously they're quite active, but we really need to see what the toxicity is like. And none of these studies reported patient-reported outcomes, which is disappointing because we really want to see how these drugs are affecting patients' quality of life. To move very quickly through to some other biomarker-directed therapies that were presented in single-arm studies. So zipalertinib, which is one of my favorite drugs to say, which is an EGFR exon 20 targeting TKI. This was presented by Helena Yu from MSK, and this was simultaneously published in JCO. So this is just the results of the Resilient-1 phase 2 study and 2 cohorts here. So zipalertinib, as I've mentioned, is an oral tyrosine kinase inhibitor, and they presented data from the cohorts previously treated with platinum-based chemotherapy without prior exon 20 targeted therapy, or patients treated with amivantamab plus or minus EGFR exon 20 TKI therapy, with OR being the primary outcome. I won't dwell on the patient characteristics, beyond to say that a third of patients had brain metastases in the platinum previously treated platinum arm. With the prior EGFR exon 20 targeted therapy arm, more than half of patients had brain metastases. In regards to efficacy, we can see here that there's an overall response rate of approximately 35%. This was higher if you'd only had, this was numerically higher if you'd only had platinum-based chemotherapy, and lower if you had prior amivantamab at 24%. This is just beyond to say that if you'd had amivantamab plus EGFR exon 20 targeted therapy, this response rate, there was a decrement to 14%. As you can see here, progression-free survival across the whole cohort, and based on the prior lines of treatment that you'd received, you can see that with more targeted treatment, the PFS, there is a numerical decrement. And overall survival data in this non-randomized study, we can see that there is a decrement if you have had previous targeted therapy for EGFR exon 20. For this biomarker subtype, we can, toxicity is quite relevant, and we could see here that, 40% of people had a dose interruption, with 15% of people having a dose reduction. And most common toxicities, not surprisingly, EGFR wild-type toxicities, including rash, diarrhea, fatigue, and paronychia as well. Then just to move on to one last study, SOHO-01 of cevabertinib, which is HER2 targeting oral tyrosine kinase inhibitor. And this was presented by Herbert Long. And basically, this was two cohorts, either naive to HER2 targeted therapy or naive to systemic therapy for advanced disease. I will just move through this in the interest of time. You can see here this is quite an active drug with an overall response rate in pre-treated HER2 of 60%, and in the naive to systemic therapy in the first-line metastatic setting, an overall response rate of 59%. This was generally well tolerated. The main toxicity primarily being diarrhea. Interestingly enough, there was more higher-grade diarrhea in patients who'd been pre-treated, and the discussant speculated this may be related to previous immunotherapy use, and there were no reported cases of ILD or pneumonitis with this HER2 targeting compound. So my thoughts, I guess, Resilient-3 is a first-line registrational study which is recruiting around the world, and their strategy slightly different to mobocertinib and more similar to the Papillon study is zipalertinib in combination with chemotherapy versus chemotherapy. It's unclear how this will stack up to other EGFR exon 20 tyrosine kinase inhibitors. So I know the sunvocertinib first-line study and furmonertinib, their comparator is chemotherapy, which is the single-agent TKI by itself. So it'll be interesting to see how this plays out in the future. Cevabertinib has an FDA priority review, and I guess it's exciting to have a number of different compounds available for HER2 mutant lung cancer in clinical trials. And there is the SOHO-02 study, which for first-line HER2 mutant lung cancer versus platinum, PEM, and pembrolizumab. I can't give a talk without talking about KRAS, and there was just some interesting data published, single-arm studies, a chemotherapy-free approach for KRAS G12C mutant lung cancer in the first-line setting. We can see here two combinations, the Crystal-7 combination and Loxo-Raz 2001. This was a study run in Australia, or had some sites in Sydney. And looking at this, we can see that this is active. Certainly the olomorasib combination looks quite active with an overall response rate of 74%. So it'll be interesting to see how these combinations progress in the future. So thank you very much for your time, and I might hand back to the chair.
Thanks, Alex. It's a great run through the advanced non-small cell information, new data. We're going to switch over to small cell lung cancer now, and it's my pleasure to introduce Dr. Lavinia Tan, who is a medical oncologist at the Peter MacCallum Cancer Centre in Melbourne. Lavinia is a medical oncologist with subspecialty interest in treating patients with lung cancer. She completed a clinical fellowship focusing on thoracic malignancies at Peter Mac, and a lab-based PhD in the Molecular Biomarkers and Translational Genomics Lab, exploring the utility of circulating tumour DNA to guide precision medicine in solid malignancies. Lavinia's main research interests focus on understanding and developing novel strategies to overcome resistance to target therapies in oncogene-driven lung cancers. So you got the pick of the bunch, I think, Lavinia, for this year's ASCO with the topic of small cell. So please fill us in.
No worries. So ASCO 2025, Chicago this year was beautiful. The sun was shining, and also what a great year for small cell lung cancer. So I'm just going to drop it like it's hot. Key takeaway points as we start. Two really important trials. So the first is IMforte, looking at lurbinectedin maintenance plus atezolizumab, which showed that it did improve overall survival in the first-line setting, but with added toxicity. So I think patient selection is key. Delphi 305, it does really affirm that tarlatamab is the new standard of care for patients with previously treated small cell lung cancer. And then what really to look forward to, there was a lot of development of other novel therapies in small cell lung cancer, such as DLL3 targeting agents and B7H3 ADCs. So let's jump in. So we know that current treatment landscape of small cell lung cancer in the first-line setting will include a platinum-based chemotherapy plus etoposide and also an immune checkpoint inhibitor. On progression in the second line or more therapy, this will then include chemotherapy. And then in 2020, we had lurbinectedin, and lately we had tarlatamab. But the key question still remains, as responses are short-lived, and also patients do not really gain long-term survival in the first-line therapy. So how do we improve first-line therapy? This is what we'll hear from the IMforte trial. What is the best second-line treatment option for patients? And now we've got the update from the Delphi 304 study. And then what are the other novel targets and also therapies that are in development in small cell lung cancer? And that's, we've got a bispecific T-cell engager, and now we've got a tri-specific T-cell engager, and also another one, a B7H3 ADC. And so IMforte, just a study overview. So this is a phase 3 randomized trial. There was 2 screening phases. So the first screening basically included patients who had no prior systemic therapy. Importantly, brain metastases at baseline was not allowed, and all patients had a very good PS. PS01. They receive an induction phase of atezo and carboplatin etoposide, so that's 4 cycles. And then if they did respond and their PS is still good, then they undergo a second screening procedure. And then the numbers did drop. But why? Who are the patients who then fell out for the second screening? It's basically mainly due to patients who progress and died. So the patients who then we are choosing a very good group of patients once again to go into the maintenance phase. They get randomized to lurbinectedin and atezo given 3 weekly or atezo alone, and there was no crossover allowed. I'll go back. So overall survival is from randomization into the maintenance phase, and here we can see that the lurbinectedin and atezo arm had an improved overall survival of 13.2 months over atezo at 10.6 months with a hazard ratio of 0.73, and this was significant. We did see that there were 9.1% of patients in the control arm who then received lurbinectedin following discontinuation of atezolizumab. So there is a bit of crossover there. But the 12-month OS for the lurbinectedin atezo arm is 56.3% versus 44.1%. So in terms of toxicity, I think anytime you add another drug to atezolizumab, so for example, adding lurbinectedin to TZO, you're going to see more toxicity, and this was definitely the case. So treatment-related grade 3 or 4 AEs was higher as expected, 25.6%, including some serious AEs of 31%. The majority of this were hematological as expected, and patients were given GCSF in the experimental arm, just to note. So there's also included more cost infusion and infusion chair time as well, just so we can take this into account. So I think conclusions from IMforte, we do see that the addition of lurbinectedin to atezolizumab as maintenance in first line does improve overall survival in patients who did not progress and still maintain a good PS after induction of platinum-based chemotherapy and immune checkpoint inhibitor, but there was added toxicity, but it was as expected. I think we need more biomarkers to help with patient selection. And in Australia, I guess there's no access to lurbinectedin on the PBS. I'm just going to jump right into Delphi 304, which is the long-awaited study that everyone's been waiting to hear the results of. So tarlatamab, if we've not heard, is a bispecific T-cell engager immunotherapy that directs cytotoxic T-cells to DLL3 small cell lung cancer. So this is an open-label randomized phase 3 trial and included patients who progressed after one line of platinum-based chemotherapy, plus minus an anti-PD-1, PD-L1, and importantly in this trial, they did allow asymptomatic treated or untreated brain metastases. And then it was randomization was stratified by prior anti-PD-1 exposure, chemotherapy-free interval, and then previous presence of brain metastases and also intended chemotherapy. They were then randomized tarlatamab, a chemotherapy of choice, which was available in the countries that participated in the trial. So typically topotecan, lurbinectedin, and amrubicin was mainly in Japan. The primary endpoint of this study was overall survival, and key secondary endpoints included progression-free survival. So baseline patient characteristics were fairly equal between both groups. Just to point out that 43 to 45% of patients really had chemo-resistant disease with chemo interval 3 days of less than 90 days. About 44 to 45% of patients also had presence of brain metastases, and almost the majority of patients actually had a positive DLL3 expression. So with the overall survival, we can see that the Delphi 304 study met its primary endpoint. Tarlatamab had a median overall survival of 13.6 months over chemotherapy at 8.3 with a hazard ratio of 0.6 that was statistically significant. And upon progression, there was a 5.8 effective crossover rate. And also just to mention, just going back, is that the follow-up for this study is only 11.2 months. So there's still more data to come. So it'll be interesting to see. In terms of subgroup, just to point out that patients who were chemo-resistant actually did better in the tarlatamab arm, and also patients with presence of brain metastases as well. They did have patient-reported outcomes in this study, which was nice to see that tarlatamab did improve symptoms of dyspnea and also cough only after 18 weeks from baseline. Chest pain, it was not significant, but it did show that it also improved symptoms of chest pain. And I think this is important for our patients to know. So toxicity, I think everyone's really worried about tarlatamab and CRS and ICANS, but it's really reassuring to see that the toxicity in tarlatamab was actually not as bad compared to chemotherapy. And even things like CRS, which was expected in tarlatamab, were mainly grade 1 and 2 with very few grade 3 tox reported. And the other tox that was seen quite frequently in tarlatamab was dysgeusia. In terms of CRS, mainly happened in the first 2 infusions, so cycle 1, day 8, day 1 and day 8. And there are ways of monitoring. They have changed some, looking at minimum required monitoring duration, so compared to 48 hours to 6.8 hours, and it's looking like we can slowly decrease this monitoring for CRS. There was one death, just to mention, from ICANS, but it was a bit complicated as the patient also had chest sepsis. So fever, hypertension, chest sepsis, but the investigator, they put it down to ICANS. So that was noted on this study. So I think Delphi 304 conclusions, I think we can say that tarlatamab really is now the standard of care second-line therapy in small cell lung cancer, but there's really further work to optimize the administration of tarlatamab so that more patients or more centers really can be more comfortable in delivering this drug to our patients. I think currently it's inpatient CRS monitoring, but there are multiple trials that suggest it can be limited to cycle 1 day 1 and cycle 1 day 8. There are also trials in tarlatamab looking at subcut administration. They are looking at novel monitoring strategies that could potentially lead to outpatient administration of tarlatamab, given education to nurses and also patients and families, and also looking at medical equipment. But also, I think we do need better biomarkers to understand which patients are at higher risk of CRS. Potentially patients with more bulky disease are at higher risk, but right now, we're not too sure. So we're going to start to see a lot of tarlatamab studies coming up. We can, the question is early tarlatamab better in the first line, or maybe in the limited stage small cell lung cancer? And there's lots of trials investigating this. And also, is tarlatamab more effective in combination? And once again, there's a lot of trials investigating this. So we will hear a lot more about tarlatamab. So we heard about the bispecific. There was also an abstract presented on elveltamig by Dr. I, and this is a DLL3 trispecific, and whether or not a trispecific antibody is better than a bispecific antibody. I think the response rate, looking at both doses, looks really encouraging at 60%. However, it is small numbers, so we need to see more data. So novel surface targets, so we've had DLL3, there's CES6, there's TROP2, and now there is a growing list of B7H3 ADCs, and they're really paving the way for promising clinical trials in small cell lung cancer. One such, so B7H3, just to say that 2/3 of patients with small cell lung cancer, they have a moderate to high expression, and it is associated with disease progression and lower survival. Looking at the different expression levels between tumor and also normal tissue does make it a promising target for antibody-based immunotherapy. And one such drug that was presented was NHB088C, which is a Chinese study. It is a phase 2 study. So it is a ADC using a supertopoisomerase payload, which is thought to be 5 to 10 times more potent than DXD. So they looked at patients with 1 or more prior line of platinum-based chemotherapy and less than 3 prior lines of systemic therapy. And they were investigating multiple doses at 1.6 milligram per kilogram, 2 milligram, and also 2.4. The primary endpoint was response rate, but just to note that B7H3 expression was not required as an inclusion. In terms of the patient population, it was fairly standard once again between all 3 arms, and also once again to note that patients with brain metastases were allowed, and there were about 20% of patients. To also say that the majority of patients did not receive prior irinotecan treatment, and once again this is important as the payload is a topoisomerase inhibitor. In terms of activity of B7H3, we're looking at the 2 milligram per kilogram cohort. The response rate was 42.4%. But you can see some deep responses on the waterfall plot and also some durable responses on the swimmer plot. How does this stack up against a growing list of B7H3 targeted ADCs? I would say that it is comparable, if not maybe slightly lower compared to IDXD and also the GSK ADC. However, in terms of grade 3 TRAEs, it is about 10% hematological AEs, 1 case of ILD, and also 1 death, which is related to drug. So I think conclusions for MHB08HC, it did demonstrate clinically meaningful and also durable anti-tumor activity in relapsed small cell lung cancer. It is well tolerated. It did have a favorable safety profile, and the 2 milligram per kilogram dose is currently being evaluated in an ongoing phase 3 trial. However, there are some questions such as what is the correlation between B7H3 expression and outcomes? What is the intracranial activity rate? And also the potential for combination given its tolerability. Lastly, I just want to give a very quick update on mesothelioma. So there was a PD-L1 VEGF-A bispecific antibody, BNT327, in combination with chemotherapy. So this was a single-arm, open-label phase 2 study conducted purely in China, given this combination, followed by maintenance of BNT327 until disease progression. The primary endpoint was a response rate and also looking at safety. I think the response looks pretty good, especially for the peritoneal meso. Sorry, I was just going to add that, both pleural and peritoneal meso patients were recruited to this study, and the response rates was pretty good for both. However, it'd be nice to see the response of the non-epithelioid versus the epithelioid subgroup, which was not shown here, I think, because they had very small numbers. And then lastly, just to say that the response rate in the pleural group was 30%. However, in the peritoneal group, they had a higher response rate of 83.3% and 100% disease control rate. So small numbers once again, and we await the phase 3 study. So will this change practice in Australia? So I think in Forte, lurbinectedin maintenance with atezo does improve overall survival in the first-line setting, but with added toxicity, so patient selection is key, and also access to lurbinectedin. Delphi 304 does affirm tarlatamab as a new standard of care for patients with previously treated small cell lung cancer, so yes. And I think biomarker-driven therapies is definitely coming, so not maybe coming, but it's definitely coming to small cell lung cancer. But I think what we really need is biomarker-driven trials. This will be really important, including further translational research. That's all from me.
Thanks, Lavinia. It's great to see all these new strategies for small cell after all of those decades. All right. Well, I hope all of you out there save room for pudding, because our last session is with Mel Itchins, where she's going to talk through her 13 favourite posters. Mel works at the Royal North Shore Hospital and Chris O'Brien Lifehouse in Sydney. She's a thoracic medical oncologist and a senior clinical lecturer with the University of Sydney, and a board director with COSA, and a co-chair on the Advanced Non-Small Cell Group and the Scientific Committee of TOGA. And she's a passionate trialist, researcher, advocate, and many other things. And I'm going to hand it straight over to you, Mel, to tell us about the top 13 posters. Go for gold.
Thanks, Laird. Hello, everybody, and hope you are still very engaged before our dynamic discussion session to come. So yes, I was, this is a nice new addition to our TOGA wrap-up session. So the posters, I sadly wasn't at ASCO, so my poster viewing was a bit more drab. I was sort of screenshotting a few tweets from a few of our Twitter alumni such as Stephen Liu. So I've got a potpourri of 13, as Laird mentioned, out of the 250 odd presented in the thoracic session. So I guess the way that I chose them is sort of clinical conundrums that we see in the clinic, things that give us headaches, things that might give us a little bit more clarity and direction. So the first one is a retrospective study conducted in BRAF V600E non-small cell lung cancer, transcontinental US, Brazil, Europe, that basically tried to understand a little bit more about the sequencing question that hasn't been looked at with the immunotherapy potential versus our combination BRAF-MEK inhibition. So in Australia, we've had a recent positive PBAC recommendation that surprised us a bit because it's sort of 6 or 7 years later, but thank you, Novartis, for DAB-TRAM. So we're hoping to start using these therapies frontline for these patients. So just to remind you, NCCN, actually does recommend if you've got your BRAF targeted, your biomarker up front to go on to a combination strategy. It even goes further to suggest that perhaps you may pause your immunotherapy and change. So this was a study that looked at again, those that received immunotherapy and chemo first line versus those that had BRAF MEK, reasonable numbers. I mean, this is about 2% of lung cancers, BRAF inhibitors. So you can see there 88 immunotherapy, 196 with the bias to using MEK. I find BRAF interesting, and I would say it's sort of shown here that, a lot are ever smokers, but there's still a reasonable proportion, perhaps 20% that we see that haven't. They're predominantly, as expected, adenocarcinoma, and the PD-L1, I guess, for all oncogenes, bar KRAS, we're still understanding what it means. But I guess in this population, you can see here that there was a bias down the bottom left there. If you had high PD-L1, you may have had more of a likelihood of receiving immunotherapy first line. This is, of course, a retrospective study of patterns of care. Some interesting things, and I guess we've learned from the melanoma experience that if you use combination BRAF MEK, you do get a slightly higher objective response rate, which was statistically significant, 62% versus 50-odd%. But then moving up here to have a look at the transposed curves for overall survival. It's a bit intriguing, isn't it, with immunotherapy chemo frontline for BRAF V600E. Although when you look at the PFS, perhaps there's a slight edge there to BRAF MEK, but I guess that speaks to how our TKIs are working also versus immunotherapy, and immunotherapy really enabling us more durable response. What I find also interesting is those that had co-mutant TP53, which we're getting now routinely in our NGS panels. Actually, you really didn't see a very, pleasing overall survival using the BRAF MEK inhibition upfront. Again, we're all looking in the clinic about whether we're being safe with sequencing, immunotherapy and TKIs. We've seen some data, sometimes we can heighten tox. And these are just basically two, again, only looking at the high-grade toxicity here, but figures just showing actually we didn't see a signal that it was concerning which way you used. The forest plots up here for overall survival. I guess, my takeaway is if you have no PD-L1 expression or if you haven't smoked, there was certainly a favouring trend to the BRAF MEK inhibition. But the others, actually, chemo immunotherapy did perform well. So, of course, this is interesting and it would be great to see further data in this space. And a similar flavour then for our MET exon 14 skip mutant population. We've had tepotinib on Medicare now for a couple of years in Australia. And again, NCCN guidelines actually mention to pivot to tepotinib or capmatinib if you do pick up your MET exon 14 skip. So they're kind of, hinting that immunotherapy is really not established, although they do mention, its place there and potentially also after TKIs. So this was a Japanese study, not big numbers, so 98 in total, that looked again at the TKI, pure MET TKI versus immunotherapy story and a little bit into the sequencing. And I would say it's hard to pick much out from it, only to say that I think jury's still out here, and I know that with Aurora in Australia we're going to look at this particular question as well, because again, MET exon 14 skip, just to repeat myself, with BRAF, but maybe even a little more, are quite a heterogeneous population. They can have a number of different histologies, and particularly some bad biology in sarcomatoid. They can be young, never smokers, older, certainly smokers, and I absolutely think that weighs into how we may be selecting potentially immunotherapy as well. I would say that tepotinib is also not without some side effects, and this particular figure down here, figure 3, took a look at if you developed edema, which I do find a little problematic and does need some serious attention with this medication. Actually, well, having edema meant that you did thankfully have a slightly more favourable progression-free survival versus if you don't. So I don't know that we're wishing for it, but that was a little interesting to look at that potential. So just looking here as well at the sequencing question, again, when you look at the ends, they are very small, but I think that tepotinib and then immunotherapy didn't do fantastically well. Tepotinib and then immunochemo. And then over here, I guess, just looking at immunotherapy on its own, if you had it with a MET exon 14 skip mutation, well, in fact, PFS 15 months, overall survival, was quite reassuring, 41 months in a historically, more aggressive oncogene-driven lung cancer. So as I've mentioned, I think that we perhaps are seeing a bit more of a signal for immunotherapy in this population. And again, interesting to think about what PD-L1 means as a predictive biomarker in this oncogene group. So this is a study that Jenny Lee has had open at Lifehouse, one of the centres I work in, and we've now opened the phase 3. So I think that this particular KRAS inhibitor, MK1084, not yet named, which is, again, a next generation sort of GDP-on inhibitor, updated data from the phase 1 is really quite interesting. So there's a number of arms to this study. I would say there's the monotherapy dose escalation. There's, interestingly, the TKI with pembro in any PD-L1 expression, and then in needing PD-L1 expression, and then regardless of PD-L1 expression, there's MK1084 pembro chemo. So down here, I guess, is showing us a little bit about the follow-up. So it's early data, 12, 17 months, a little bit on the AEs, but we won't, in the interest of time, talk through, because I guess here in the middle is just a signal for, the activity. So as a monotherapy, objective response rate, again, in a difficult biological group, 38%. I particularly like the pembro MK1084 waterfall plot here, which is looking really quite reassuring, with durations of response, not met, and high objective response rate there, 77%. And again, agnostic of PD-L1, even non-expressers, the chemo combo, interesting, but I think the signal is here. So giving the combination, however, transaminitis, as you can see here for arm 2, so that's the pembro MK1084, a little bit more of a flavour, I guess. So any transaminitis in 38%. So, of course, we'll need some careful driving and understanding moving forward which drug to hold, etc. So the last thing to say, I guess, down here is what's really interesting is in this particular, looking at the high PD-L1 expression, 50% or above, those ones really seem to benefit from pembro MK1084, and that's the one gone to phase 3. So interested, to see how that plays out. So just a brief one, I guess. We've had selpercatinib now. We've seen the data since around 2018 for RET inhibitors. We're doing routine testing in most centres for RET fusions. We're starting to now see selpercatinib resistance coming through. A really important population. This is some Chinese data. We've seen the turning point data, I think now acquired by BMS, TPX0046, don't quote me on that, but a RET inhibitor that is active when we develop the RET resistance mutations to selpercatinib or pralsetinib, the RET V804, G810. So this is just looking at the dose escalation, first look data of 40 patients, 30 had efficacy. So this is quite a potent RET inhibitor. I should mention that resistance to first-line selpercatinib, really a lot of patients don't have on-target, these gatekeeper kinase domain mutations. About 20% only do. So, it's a heterogeneous group. But I guess what's interesting is this looks like a more potent on-target inhibitor. So perhaps it will be one, I hope, that bears out, as we saw quite encouraging objective response rates here in small numbers, but 75%. And again, the transaminitis was a flavour. And I would say hypertension for RET inhibitors is also a pathway that certainly does need a little bit of clinical attention for us. My thoughts here are, how do we keep this field moving in these important spaces for our patients and drug development and niche areas? We saw pralsetinib, the phase 3 pull up early because of, perhaps the competitive market. So let's hope, as I think we're all needing more options, for these important groups. So the MassGen group, proliferative in the ALK drug resistance space, had a nice informative poster on drug resistance to ALK inhibitors, focusing on the current clinical landscape, which is mostly those developing drug resistance, having not received crizotinib, as things really do change as you develop your resistance to alectinib, brigatinib, and lorlatinib. So this is a really nice program they have, and I guess it's just for us all to feel like, oh, this is the dream. But where they're doing matched tissue biopsies at resistance, looking at liquid whole exome sequencing. So what's important, and a flavour that we've known for a while, is if you've had next generation ALK inhibitor, and this is shown here, in those that have had in green no prior crizotinib, met as a pathway of drug resistance, as we heard also from Alex with the EGFR story, happens in about 15%, perhaps more if you've had only lorlatinib. Again, if you've had a second-gen TKI or a second-gen and then a third-gen being lorlatinib, it is far less likely for you to develop an on-target ALK resistance mutation, which may mean then that it is not as fruitful for you to go on and have, for example, a fourth-generation ALK inhibitor, which is coming through into the clinic in neladalkib. What was not presented in this poster I could see is those that had only had lorlatinib. As Ben has presented, those data actually where we haven't seen any on-target ALK kinase domain mutations as the mechanism of drug resistance in those, that are having upfront LOLA. But I think that the comment to this poster is, again, we need to be seeing novel ways to salvage drug resistance, looking at off-target and rational combinations of drug therapy. So then moving on to a study, again, of a new generation MET ADC. We also had this at Lifehouse, one of my centres. So this was the phase 1 data for a really interesting novel MET ADC that actually has quite an interesting construct that confuses me, but it's basically PhD dependent, and the payload of the MET ADC, which has an MMAE payload, basically preferentially goes into the lysosome and doesn't recycle back to the cell surface. And long story short is that's good for toxicity. I would say that toxicity is good with this ADC, but so we don't see the asthenia and the myelosuppression and some of the stomatitis that we see, for example, from our TROP ADCs, for example, but we do see corneal epitheliopathy. So this has been a study that has needed some really intricate eye drops and a lot of ophthalmology appointments. And I think there's still a finessing going on for doses, but they've at the moment expanded to 4 mg per kg. Now, it's definitely effective. So here are the cohorts that have read out. This was everyone that went into study, irrespective of if you had any MET immunohistochemistry positivity, so all comers. And, you can see the tumours respond, and we certainly have seen that, including in those that have oncogenes, an important population. And then in those that have any degree of MET positivity, which is the group that are now being carried forward, objective response rate about 40%. And in this study, the median, previous lines of therapy was about 3. So they're pretty, pre-treated population. So really interesting, continuing to expand. So leptomeningeal disease, of course, a really big issue for us all. We're keeping people, thankfully, alive longer. Unfortunately, a sanctuary site is no doubt LMD. We know that patients are largely excluded from clinical trials. We sit there and we try and work out how do we help these people. So this was a nice study from China. It was actually a prospective study that looked at recruiting those with LMD in to have a higher dose of third-generation EGFR TKI furmonertinib. So these were in an EGFR population, sorry, I should mention. And then looking at adding pemetrexed, most was intravenous, some were intrathecal, but let's not go there, with bevacizumab. And I think, because the other really meaningful thing that we find in the clinic with LMD is we want to avoid whole brain radiation. We want to give people more meaningful time before going in and irradiating their brain. And these trials seem to do that. So with LMD, we often see in studies clinical response evaluation. So I guess that's remaining neurologically intact and reasonable quality of life. And that was seen in this group in most. And there were reasonable objective response rates, actually, objectively 60%. Cytology became negative in the CSF in a third. And I actually think that when you look at it tolerability-wise, because that's where we're going to get criticised, in our clinical practice, aren't we, if we're going quite off script. But I thought it looked reasonable. I guess, grade 3 toxicity rate very low. Of course, we have to be careful of particularly diarrhea using Bev and a higher dose of TKI. So another, and I guess I find the MTAP story at the moment very interesting. So this is a methylation pathway that's now getting a lot of airtime in non-small cell. It's like we didn't know about it and now it's everywhere. And I guess because if you have CDKN2A deletion on your targeted panel, it really is a hint to us now that we're dealing with, MTAP loss. And, about in this particular series, which was a big series from the Asian registry LC Scrum, basically they looked at, how many patients have they looked at? Sorry, I can't actually remember that, but a lot. So 250. And they showed that, the incidence of MTAP loss in non-small cell lung cancer, 20%. So this is a pathway that's, dysregulated in 1 in 5. What happens in MTAP loss? So, it's a methylation pathway within the cell where if you lose the MTAP gene, you basically get an accumulation of an enzyme MTA that pushes PMRT5, as a pathway that, preferentially enables oncogenesis, to really simplify it. So if you inhibit that with the PMRT5 pathway, which that cell's kind of now relying on, well, actually we can see responses, and tumours. We've seen data for single agent, such as in AMG 193, for response in non-small cell lung cancer. Because MTAP loss actually predicts for a cold, phenotype of cancer, and this particular series looked at that. So they saw in MTAP loss, you had, a significantly lower tumour mutational burden, you had lower PD-L1 expression. They looked at the demographics of the patients, and they really couldn't see any different. It looked like, squame, adeno, oncogene, you could have MTAP loss, smoking, non-smoking, and really, these curves just speak to, in small numbers, of course, that immunotherapy didn't really perform as well. So for me, I think it's super interesting to start to understand what else, we can do for these tumours, because we're often getting this information at diagnosis. And also we're seeing it as a potential acquired resistance, such as in oncogene-driven lung cancers. So moving then to mesothelioma, where it's even more common. So in fact, in 30% of mesos, we're not generally doing genomic testing in routine clinical practice, but this is a brief study to basically say in a meso population, they found in those that received immunotherapy, so those with the red lines here, actually you had an attenuated response to IO. And I think, for me, this tells me that maybe in Checkmate 743, the frontline Ipi-Nivo study, we know there was equipoise between chemo and Ipi-Nivo for epithelioid. Well, maybe this marker could help us to select those that are more likely to benefit from dual IO. So another brief one, and I guess I probably will get a gong soon, but I'll just keep talking until Laird tells me to stop. But this is interesting. So this is MD Anderson basically looking at their immunotherapy use in thymic malignancies. I mean, we'd love to be using it. Sometimes we do, but it's not easy to access. So in about 40 patients with thymoma or thymic carcinoma, what happened? So I would say let's go straight to efficacy. Well, if you had a thymic carcinoma, you were more likely to have a response than perhaps a thymoma. But interestingly, they used immunotherapy in thymoma, and I found that a little controversial. They didn't talk about the selection, but they saw toxicity in thymoma in 100% of cases. One died from pneumonitis, and there was a grade 3 myocarditis. Interestingly, this figure says it's a thymic carcinoma and then it's a thymoma. And I find that really difficult with thymic data. There's an interchanging of the biology, and they're different biological cancers. But my take home from this was, I think in thymic carcinomas, from this poster, yes, we do see efficacy for checkpoint inhibitors. Thymomas, there's still a big caution around the immune-mediated toxicity, which is super high. A brief talk, as I've been told. Okay, this slide basically tells us if we do comprehensive genomic profiling, which is super expensive, actually you get better survival, you get onto better drugs, and you maybe cost the healthcare system about the same. So it's not always, there's nice ways, and this is big Medicare data. This is a brief study looking at if you become lymphopenic with Pacific, unfortunately, you do significantly worse. I don't know what to do with this data, but I think we all give chemo rads and then durvalumab, and we see the lymphocytes drop. And unfortunately, there's a 48% increased risk of death, in this particular population of 118. So do we need to change what we're doing with the radiotherapy? Do we need to look at other lymphocyte stimulating therapies? Because this is a group that underperform with chemo, rads, durva, and Pacific. And then my final slide is super busy, but it brings us full cycle to what Rachel was talking about with PCR, looking at NeoCOAST. How do we get more people in the PCR lane, with a resectable lung cancer? So we saw early NeoCOAST data. Rachel said 1 in 4 from Checkmate 816 had a PCR, and the curve stays flat. So this is basically a number of arms from NeoCOAST, looking at oleclumab, anti-CD73 with chemo durva, looking at monalizumab. I can never remember that one. It's an NKG2A novel immunotherapy, or datopotamab deruxtecan or Dato-Dxd. So where do the ADCs sit? Maybe they sit in the neoadjuvant circumstance, and you just get 4 sharp cycles, not indefinite ADC. in short, yes, it could push PCR up. So it could push PCR up particularly. So here it's MPR and PCR in all of these in the middle, but in squames, I think that's really important population. And overall, you know, we could see PCRs going up to about 40%. Of course, with some trade-off of toxicity, you know, as we mentioned earlier with the TROP ADCs, a bit more baggage. But, you know, perhaps if it's 4 cycles and done, it's something we can get people through. Because down here, I would note that most people, you know, got to the operation. So that's obviously always a super important point. And then the final point to say is they used a methylation assay called GRAIL. And as Rachel said, they definitely showed that if you cleared, you know, your detectable DNA in the blood via that MRD panel, you did better. So there's hope in the future for that type of technology. So that was me done. A quick whiz around some posters. Thank you.
Thanks, Mel. Nailed it. And nice finishing poster on early stage to take us right back to our first session and put all this together. So we have got 10 minutes for discussion, and I want to prioritise some questions that have come through from the audience. So I'm going to crack straight into the first one, and I'm looking at you, Rachel. It's regarding Checkmate 816. It says here, the Checkmate 816 control arms seem to do really well, which is true. 55% alive at 5 years with chemo alone in that neoadjuvant space. Did they present subsequent treatments for that control arm, especially any immunotherapy at relapse?
Yeah, no, thank you for that question. That's great. So I probably should have included that detail. So no, but they did. So yes, about 50% of patients that were in the study of Checkmate 816 in that chemo only relapsed and got further treatment. So of that group that had further treatment, 78% had systemic treatment. 50% of the group had immunotherapy. So quite a proportion, but also just to bear in mind that not all of these patients at the onset we knew their EGF and ALK status. So 12% went on to TKI for EGFR and ALK. So that might have influenced their outcomes. But yeah, 50% of the patients got immunotherapy in that sort of second line space who didn't have it initially. So quite a reasonable number, I think. Yeah.
So I mean, I suppose better treatments at relapse for advanced disease compared to those, what was it, the ANITA study? There was none of that going on at relapse after ANITA, was there? So it's great to have the control arm shift up.
But it still then means that we've got that 10% numerical benefit from the immunotherapy, just at 3 cycles up front. So I think that it shows the value of that probably even more so, potentially. We've still got those curves quite separated at 5 years. So that neoadjuvant approach, I think, is quite useful.
Yeah, so just for the wider audience, Checkmate 816 is funded in Australia, but not yet in New Zealand, especially with overall survival data. We've got some work to do because we want it. Okay, so I am going to jump straight across into the small cell realm there with you, Lavinia, because another question that came through was a pretty simple one. Are you going to be recommending the addition of lurbinectedin to your atezolizumab maintenance therapy tomorrow? Do you think it's worth it for the benefit, the tox, the cost?
Yeah, I think the data is there. It is just statistically significant, but of course, what is clinically meaningful obviously will be a discussion between us and the patient. As maybe 2.5 months is not meaningful for some of us, but for patients, I think that's definitely very meaningful. And I can see that there is a cost share program capped at $20,000, and if a patient is willing, I think I would say yes.
Yeah. Any other thoughts, Alex or Mel?
Yeah, I mean, it's for me, I enjoy that period, that honeymoon period after your chemo. I think the small cells have earned that, haven't they? So, I did look at it and I thought I definitely talk to patients about it. I think uptake will be 50-50 if I'm honest, if it's more available. And if the nausea is really a problem or the myelosuppression, you may opt out. Lurbinectedin sometimes does need that extra attention, but, it's definitely a really positive study, and 3 months overall survival benefit for small cell is great. So discussing it. I'll be interested to see how the uptake plays out.
Yeah, I think when I think about the standard of care over here, where there is no immunotherapy for small cell, there's kind of two jumps, right? If we go straight to the combo, it's actually 6 months compared to chemo alone if you're adding up all those studies. But again, you don't get away from hospital and go on that holiday and feel good before the relapse. So it's a real patient-centered discussion, I think.
And also, so the OS is from randomization as well, just to remind everyone. So technically, patients already responding, those patients who go on to maintenance have already responded for at least 3.5 months or so before going on to the maintenance phase.
Yeah, absolutely. Alex, you're not left out, mate. I'm interested in the time of day study. And the question is, what's stopping us? What's to lose? And just starting that tomorrow, are you a believer?
I mean, randomized data is randomized data, so it's kind of hard to argue with that. I guess it's a resourcing thing. I mean, we can, trying to get all our patients into our chemotherapy suite is kind of like playing oncological Tetris sometimes. So pieces just move where they have to. I think for chemo, obviously the data is there for chemoimmunotherapy, and most of those patients tend to start earlier in the day because it's a longer day. It's really, if we see this validated in more cancers with single agent IO, that's going to make things more challenging. I mean, I'm always passionate about my patients starting earlier in the day just for their convenience, but I'm sure this data will get disseminated and patients will be keener to, start earlier. And I think we should facilitate that.
But,
I feel like we should prefer the morning, right? I mean, we should ask. The scheduling is a bit of a nightmare in some cases, but in others, it could be a no-brainer.
I was going to mention, if this is about the circadian rhythms and your immune cell activation, I mean, it's going to be agnostic of the primary side of the cancer, right? Even though you've said it maybe needs to be validated, but does it? The only other thing I'd say is our supportive care colleagues kind of say, don't tell your lung cancers to come in too early in the morning, right? Because they take a little bit longer to get ready of a day. Just a small plug to, when we do our early morning clinics, always being told by our patients they don't like coming in that early. But
I can't get my head around is the whole half-life and effectiveness of the Keytruda. Like, how does that even work? Maybe it's all in effect from the very first one you give. I'm just not sure.
Yeah, I mean, that's the kind of speculation online, but it needs some smart person to really delve into it and, work it out for us. But it doesn't seem to be related to drug pharmacology. You'd think it probably host-related in some way.
Now, I can't see a question, but we have to talk about Delphi, Lavinia. What strategies do you think will help the practical implementation of tarlatamab in the second line? Let's just pretend it's all free drug. The fear and the management of CRS, where do you think we could move this to make sure rural and remote areas get the same access to an effective treatment?
Yeah, so I think, we did talk about this in our clinic, in our lung cancer group as well, saying it's like when immunotherapy started and all of us were so afraid of, all the immune-related toxicity. But I think with Delphi, it's quite reassuring to see that, the CRS are mainly grade 1, grade 2, so it's manageable. I think it's true that definitely, we need to make it more accessible, as you say, to different sort of regional hospitals. But, I think different hospitals are comfortable with what they're comfortable with. I think we did hear of one hospital admitting the patient to ICU actually for the first dose just to monitor the patient, but then nothing happened really. But, they just took that extra level of caution and just to monitor the patient there. I think it would be nice to see how the monitoring strategies will evolve as we learn more how to manage CRS. And it's good to know that it's mainly in the first 2 doses. And then there are other strategies like looking at, whether subcut will help, whether can we then slowly move it to an outpatient setting as well. And then that will be definitely, the uptake will be higher, I think. ICANS was a little bit more tricky, I think, to really, diagnose ICANS is quite hard, I think, in patients. And so, there was one death related to ICANS, but even that, I think the investigators all thought that it was mainly due to potentially sepsis as well. So it's hard to say whether it was ICANS or sepsis, but, a lot of the symptoms are together. Yeah. So anyway.
A quick note that the New Delphi studies, you don't get admitted. So I think 303, you need to be in a 1 hour radius, and you have a card that you would present if you needed to come in, if you're febrile, for example, to emergency. So there'll be a lot of upskilling of the workforce.
Yeah. I think education. Yeah.
Yeah. I mean, there's another question came through, jumping back to the time of day. There's a lot of interest, talking about how all of the clinical trials with those long sort of PK requirements, trying to get all of their morning drugs in and then monitoring and taking levels, and how it could make a huge impact on all sorts of aspects of care. I think it looks like it's more of a comment of how hard it might be in reality. Okay, I had a question actually back to you, Rachel, because I think, we've got 1 more minute on my clock at least. And it was about the Neo-ADORA study. So having that osimertinib before in resectable cancer, is there, to me, NPR is not going to cut it. That's my opinion, as an outcome to change practice. But do you think there's a group there? Maybe those N2 where we don't really want to give the chemo-rad multi-stations. Do you think there's a role?
I think it'll be useful to look at the larger tumours with the N2 disease. I think that might be a role. There's also mention. I mean, I agree. I don't think NPR is like a PCR when you're on immunotherapy. That's. I think there was was it maybe even Patrick Ford said they're apples and oranges. They're different sort of endpoints really. And again, with Neo-ADORA, we've only got NPR. We don't have EFS. We don't have survival. EFS will be interesting, because it does look like the 3 groups have got equal uptake of OSI post-surgery. So that actually makes it a bit more even in terms of seeing whether the neoadjuvant approach is useful. Someone mentioned something about whether patients with TP53, would be good to look at that. But there may be a role for those bigger tumours with the N2 disease. There was, the data about nodal downstaging. But we're still talking about upfront resectable patients. I think in any of these neoadjuvant studies, the patients have to have resectable disease upfront. We're not talking about downstaging. But obviously we know that quite a few of these patients with EGFR mutated lung cancer do go on and have metastatic disease, which is why ADORA was so positive. But yeah, I'm not sure whether we'll be using it, but you're right, maybe for the bigger larger tumours with N2 disease. I'm wondering what the other panellists think about whether we will be seeing this in clinic.
I'm a believer. I hope that it helps eradicate micrometastatic disease, and I hope we see the curves split, so because we know EGFR lung cancers unfortunately are inherently a more advanced illness, even with all of our, surgical preoperative staging. And I guess I think about it as many in ADORA in that N2 positive, population had chemo, so front loading it, getting it in before the operation as well. I like it. But as you said, very early data before we change the practice.
Yeah. Time will tell. And I think time has told, because we've just hit the end of the session. So I wanted to, first of all, thank Rachel, Alex, Lavinia and Mel for your presentations and also sharing your opinions in this discussion. I need to thank Pfizer again for their sponsorship. But most importantly, I want to thank all of you out there from across 2 countries for attending. If you didn't, we'll all just be talking to ourselves, which would be a waste of time. So thank you for spending your evening with us. A little plug for TOGA ASM, late July in Brisbane. It's going to be a fantastic meeting. And the last thing I'd ask as a favour is to complete the feedback for us. So I'm just going to close with a Māori karakia and then let you all get on with your evenings. Unahia, unahia. Unahia ki te uritapa nui. Ke wātia ke māma te nākau. Te tinana, te wairoa I te ara tangata. Koera e rongo, whakaere ake ki rongo. Kia tina, tina huye tā ki e. Ka kite anō and have a good night.